you for the Jyoti Day Forum invitation. You know, importance this evening to drive home is the fact that sugar needs to be controlled, the control needs to be maintained, and the benefits of this control needs to be harvested over a period of time. So if you talk about a drug and say, dekho, fasting sugar has come down, A1C in 3 months is normal, I'd like the patient to come back after a year and see where his A1C is. I'd like to see this patient followed up to look at his complications. Remember, I just spoke in the neighboring auditorium where I talked about the Asian phenotype. The Asian Indian phenotype, we get diabetes a decade earlier. We have thin fat Indians, a thin man but still abdominal fat. We do not have pre-diabetes. We move quickly from pre-diabetes to frank diabetes. We do not respond to monotherapy well, and unless we don't hit hard, our sugars don't come down. This is my disclaimer about a better move. In this game of chess, which is diabetes, where you have lots of people to play with, lots of men to put around, you need to put your best foot forward. And diabetes, which is the fastest growing health emergence of the 21st century. 46% increase in the world. Europe, North America, Western Pacific, America, Africa, everywhere. But I'm more interested in Southeast Asia. A 68% increase. Middle East, 87% increase. 537 million people between the age of 20 and 79 worldwide are living with the diabetes, and the numbers are rising. India is now the diabetic capital. High prevalence rates of diabetes. And the number of people living with diabetes is predicted to reach 152 million by 2045. It has long been noticed that individuals of South Asian ethnicity have a higher risk of certain NCDs, especially type 2 diabetes, as compared to the Caucasians. And the number of people with diabetes has dramatically risen in the last decade. The long-term durable glycemic control is a difficult goal to achieve in Indian patients. Indians are very restless. You see the batsman at the opposite side taking guard and hitting strokes in the air. He can't wait to get struck. Indians want to get off drugs. Dekho, mera sugar theek hai, abhi to dawa kam karo. Where's the question? Abhi aapki aankh theek hai, to chashma pehenna band karoge? Will you stop wearing glasses because your vision is normal? These patients have to be told that despite well-defined treatment, patients soon become poorly controlled if their existing therapies are inadequate. And 77% of type 2 diabetics in India have a poor glycemic control. An important treatment goal in type 2 diabetes. Remember, there is insulin resistance, there's beta cell dysfunction. All this leads to a progressive nature of the type 2 diabetes, inability to maintain glycemic control, and increased risk of micro and macrovascular. I'll give you the same analogy of vision. You take off your glasses, you don't see well, so you promptly put them on. You stop your diabetic medication, you develop an infarct after 3 years and tingling numbness after 8. So the cause and effect phenomena is later, so patients don't realize it. Need of the hour is therefore intensive, long-term glycemic control to reduce the risk of complications, to improve the quality of life, and to reduce mortality. And most guidelines recommend A1C of less than 7 as the general target for glucose control for optimum management. Long-term durable glycemic control remains difficult due to the progressive decline in beta cell function and our fault, clinical inertia. Early achievement of A1C level within the target of glycemic requirement is an important determinant of glycemic durability. And the benefits of intensive long-term glycemic control in this meta-analysis from randomized controls trial over 5 years, where intensive versus less intensive glucose control, 20% reduced risk of microvascular kidney events, 13% reduced risk of eye events, reduction in blood pressure, cholesterol, and its atherogenic fractions. If you control your patient's sugar wells, the nephrologists in your city will be out of business. More than 50% of CKD comes from diabetes. The cardiologists will have to keep their catheters on their shelves. You have to be after them. And how are you going to do it? You have to get on target. And that's extremely important. How do we achieve it? This was a study, a multinational and multi-ethnic study. Why am I saying this study is important? Because despite the fact that it was done in 250 centers in 34 countries with 2001 people, it involved Southeast Asia and particularly India. And that's important because the Indian diabetic is different. This study design were a randomized double-blind 2-arm parallel group study consisting of a screening visit, a 3-week run-in period with treatment intensification over a 5-year treatment period. You see, patients were split into 2 groups, one on metformin who was given vildagliptin, the other metformin who was given a placebo. 6 months or longer if the blood glucose levels did not get worse. Same was continued for the above. The lower one, Vilda, was added, especially if the blood glucose level got worse. And in the period 3, insulin was added if it was required. Lower one, 2, insulin was added in either group if the levels continued to worsen, and the study was followed up for 5 years. What was the result? The risk for time to initial treatment failure. You began treatment with 2 drugs. When did these 2 drugs fail? When you gave monotherapy versus dual therapy. A 49% significant reduction in risk of time to initial treatment failure with the combination treatment of Vilda and metformin. So you can see the number of patients who failed were much more with mono, 50%. Patients on metformin monotherapy tend to fail earlier, and the median time for failure was 156 weeks as compared to the combination where it was 269 weeks. In the textbook of diabetes, right in the first page, there's one library which I saw in the US which said oral hypoglycemic agents are good, but one day failure is a must. So you will get failure and you will need to innovate, increase, add other things. But if you can delay the failure by initiating with the right combination, you will get a good result. And the risk for time to second treatment failure, where both were given and still required 26% significant reduction, to second treatment failure with combination of Vilda plus metformin over 5 years. So it delayed initial and second treatment. what was the Indian subset analysis? The Indian subset analysis, if you look in a close-up fashion, how did verify mean and smell for India? Of the total number of Asians participating in this global verify study, 47% were Indians. Risk for time to initial treatment failure in Indian patients with combination versus mono, 53% reduction in risk of time to initial treatment failure. Indians had even a better result, 49 internationally, but 53%, showing that Indians benefited more, a 4% jump when you gave them combination therapy. The Indian patients on metformin monotherapy tended to fail early, and they failed early at 1.5 years versus 3 years. And the median time for monotherapy, if that was 156 weeks, ours was 78 weeks. So this was extremely important. The Indian diabetes fails early on monotherapy. Now, what happened then? The median time to initial treatment failure, early combination versus early monotherapy, 50% of patients failed on metformin monotherapy as early as 1.5 years versus 4.75 years for early combination therapy. And the risk for time to second treatment failure, early combination therapy versus initial monotherapy, 58% reduction in risk of time to second treatment failure with early combination compared to initial monotherapy. So India believes, and a lot of our physicians treat to fail. Start a tablet. It doesn't work, I'll give you a second one. If that doesn't work, I'll give you a third one. Why can't we follow the verified results? Don't treat to fail, treat to succeed. I'm going to give you a combination. A1C comes down, you improve your lifestyle, you're able to maintain it for a couple of years, I might reduce the dose or then decide about therapy. So early combination therapy, this has been adopted by both ADA and EASD. It's a step towards better life with diabetes, where if you give them early combination, even in the newly diagnosed patients, the two of you put together with two drugs can cycle faster, can cycle longer, and not get fatigued. So you look after the organs, you keep the sugar durable, and you do not lose treatment failure. Therefore, this picture to show you how two drugs work better than monotherapy. The guidelines shift standard conventional management to early combination therapy. ADA-ESD consensus of 2018, providers should engage in a shared decision. Early combination therapy based on the perceived need for additional glycemic efficacy or cardiorenal protection can be considered at treatment initiation to extend the time to treatment failure. This statement was in 2022, and in younger patients with diabetes, less than 40 years of age, consider early combination therapy. And here we take a leaf out of the legacy effect. You treat early, you get good glycemic legacy. And ADA 2023 says that early combination therapy can be considered in some patients at treatment initiation to extend the time to treatment failure. Now these are consensus from America. Americans who have 20% of the diabetes are trying to tell Indians who have 50% of diabetes how to treat. We know our Indians. The Verify trial has shown how we Indians behave. Let us pick up our own evidence and let us help our patients with the results of this Verify trial. So, in a nutshell, the summary is India has a high burden of diabetes, with more than 75% having uncontrolled A1C levels. Indian type 2 diabetes tend to fail on metformin alone compared to the global diabetic population, indicating a faster or a malignant progression of disease. Early combination treatment approach with Vilda and metformin in newly diagnosed type 2 diabetes patients significantly and consistently improves glycemic durability compared to mono alone. And recent international diabetes care guidelines also recommend the use of combination therapy to extend the time to treatment failure. Thank you for your attention.
Any questions?
Sir, what was the A1C that was told as failure and success of treatment?
So the A1C, the durability, if you didn't bring it down to under 7 was the cutoff point.
Right. My question was if imagine like in a patient who is already on, we are starting treatment, somebody is starting with 6.7, we start treatment, definitely with metformin, right, single agent. So if we start off with Vilda plus metformin and we are achieving an HbA1c of 5.8, will we continue on that? Or
So here we talk about A1Cs of 8 and close to 8 when we give the combination.
Yes, that was the question.